You know, it's a strange thing. Sometimes when we're curing one disease, we can actually accidentally create a whole new problem. Today we're going to dive into a really complex medical issue that often shows up after a successful cancer treatment. But more importantly, we're going to look at the incredible surgical innovation designed to fix it and give patients their quality of life back. And this quote, wow, it really hits the nail on the head. We are talking about something called a rectourethral fistula, or RUF for short. And yeah, it might be rare, but for the person going through it, the impact is absolutely massive. It's a condition that can just turn the most basic parts of your daily life upside down.
So what exactly is an RUF? Let's break it down. Basically, it's a tunnel that's not supposed to be there. It's an abnormal channel that forms between the rectum, which is the last stop for your digestive system, and the urethra, the tube you pee through. Now, you can probably imagine having those two systems connected causes some really devastating problems with urinary function, bowel function, and even sexual function. It just fundamentally changes a person's life.
All right, so here's our game plan for this explainer. First, we'll dig into why RUF is such a devastating problem. Then, we'll look at the huge challenge of just planning the repair. After that, we'll walk through the incredible surgical solution, check out the data on how well it works, and finally, talk about the long road to recovery.
So, you might be asking, how does something like this even happen? Well, for a long time, the main culprit was a major pelvic surgery, like having your prostate removed. But, over the last couple of decades, that story has changed a lot.
And the symptoms, they are immediate and, frankly, pretty awful. The classic signs are things called fecaluria and pneumaturia. We're talking literally feces or air ending up in the urine. And that contamination just kicks off this terrible chain reaction. You get constant urinary tract infections, painful abscesses, and in the absolute worst-case scenarios, life-threatening sepsis. It really drives home why this is called a devastating complication.
Okay, now this is where the story gets really interesting. Look at this shift. Before 1998, less than 4% of these fistula cases were connected to radiation for things like prostate cancer. But then, fast forward to the period between 1998 and 2012, and that number skyrockets, to over 52%. So what this tells us is that as we've gotten better at fighting cancer with radiation, this specific complication has become a brand new, major challenge for the people who survive.
So, we get the problem, right? But fixing it, well, that's a whole other ballgame. Repairing an RUF is known as one of the most difficult procedures in all of reconstructive surgery, and for some very, very good reasons. I mean, just think about the challenges here. The fistula itself is buried deep inside the pelvis, which is a super tight and hard-to-reach space. Then, the tissue you're working with, it's often in terrible shape, especially after radiation, which leaves it all scarred up, fragile, with a really bad blood supply. And all of this is happening right next to the critical nerves and muscles that control whether you can stay continent or have an erection. So this is definitely not a routine surgery. It takes a super specialized team at a center that does a lot of these.
And this flow chart? It perfectly shows just how complex this is. This isn't a simple A to B plan. It's a decision tree surgeons have to navigate. See how right at the top, the path splits depending on what caused the fistula, surgery or radiation. And from there, it just keeps branching out. This really shows you that the careful planning before the operation is every bit as important as the surgery itself.
So, to give the patient the absolute best shot at success, there's a ton of work that happens before they even get to the operating room. They'll do a joint exam with both urology and colorectal surgery teams. They'll almost always do a temporary colostomy to divert stool and keep the area totally clean for healing. And for those radiation cases, this is crucial. They'll use hyperbaric oxygen therapy to help grow new blood vessels in that damaged tissue. It's all about getting the body in the best possible shape to heal.
All right, now let's step into the OR. Because the solution here is, well, it's pretty brilliant. This isn't just about patching a hole. It's about totally rebuilding the area with healthy, living tissue.
And here it is. This is the problem, right up close. You're looking at an intraoperative view of the fistula tract itself, that abnormal channel connecting the two systems. The surgeon's first job is to painstakingly dissect out this entire tract, get it fully exposed, and only then can they divide it and start the reconstruction. So the main way surgeons tackle this breaks down into 4 key steps. First, like we said, expose and divide that fistula. Second, they close the hole in the rectum, usually with 2 layers to make it strong. Third, they close the hole in the urethra. But that final step, step 4, that's the real game changer. They place a healthy muscle, one with a great blood supply, right in between the 2 repairs to act as a living wall.
So where does this healthy muscle come from? Take a look. On the left, you can see the surgeon harvesting the gracilis muscle from the patient's own inner thigh. It's perfect for the job. Long, thin, and has a great blood supply. Then on the right, you see that same muscle after it's been carefully tunneled into place, getting ready to be positioned between the two repairs. It's like a feat of biological engineering, moving a piece of the patient's own body to where it's needed most.
You might be thinking, wow, that's a lot of work just to move one muscle. But there are some absolutely critical reasons why they do it. It physically separates the two repairs, so they can't break down and connect again. It fills in the empty space created during the surgery. But most importantly, it's like bringing in a fresh supply line, a new healthy blood supply to an area that's scarred and damaged. That is absolutely key for healing and for making sure the fistula doesn't come back.
So, the technique is amazing, right? But does it actually work? Let's look at the numbers, because this is where you see the real-world difference between a fistula caused by surgery and one caused by radiation.
What we're going to do is put these two groups head-to-head and look at the success rate after just one surgery. This is really the most important takeaway from the biggest studies on this.
First up, fistulas caused by surgery. We're talking healthier tissue generally, and the success rate? An incredible 98%. Just amazing. It shows you how effective this whole approach is when the conditions are right.
But now, look what happens with the radiation-induced fistulas. The success rate drops to 86%. Now, don't get me wrong, 86% is still really, really good. But that 12-point drop, man, that tells you everything you need to know about how tough radiation-damaged tissue is to heal.
And if you look at the complication rates, you see the exact same story. For the non-radiated patients, the risk of a serious complication is super low, just 2%. But for radiated patients, that rate jumps more than 10 times to 22%. And again, that's not about the surgeon's skill, it's just the tough reality of biology. Radiated tissue is just incredibly hard to work with.
And you know, even after a successful first surgery, the journey isn't always over. This image right here shows a problem that popped up years down the road, this little pouch or diverticulum that formed in the urethra. It really highlights that these delayed complications can happen, and it's why these patients need to be followed closely for a long, long time. Okay, so this brings us to our final thought here. This whole thing, from the initial diagnosis, through the repair, and into the long-term follow-up, it really is a story of survivorship. It's about learning to navigate these incredibly complex problems that go way beyond the original cancer itself.
And, the moment surgeons feel like they've mastered one challenge, another one, sometimes even tougher, pops up. This MRI shows a related problem, and it's arguably even more complex. It's a puboprostatic fistula, or PPF. And here, the fistula connects directly to the pubic bone, which often leads to this deep, nasty bone infection. It just goes to show you how this field of surgery is constantly having to evolve. And all of this, really, it boils down to one big, important question. A procedure like the one we've just walked through isn't just about fixing an anatomy problem. It's a powerful answer to the question of what happens after the cancer is gone. It represents this ongoing, incredibly complex, and deeply human mission to not just help people survive, but to restore their function, their dignity, and truly give them their lives back.